All right. I think we can start. So what we have for today is a 28-year-old male. He's altered mentation for one day.
Okay. Well, maybe before I start, let me just say this is a disclaimer to everyone. Jose aliniambia hii kesi ya leo ni ngumu sana, kwa hiyo he bet me kwamba most likely sitapata diagnosis, so I'll approach the case nikiwa niko relaxed because I know it's very likely that I won't get the diagnosis, maana ameamua kunikamia. Well, so altered mentation for one day. Well, at least might be a difficult case, lakini angalau nitakuwa na mawili matatu ya kusema. So for altered mental status, the way I approach altered mental status, so this is a 28 years old male altered mentation for one day. So the patient is presenting with an acute onset of altered mentation. That's a one-day history. So when I think of altered mental status, I'll just start broadly because it's a broad complaint, and therefore I won't commit myself to anything particular at this point, but I'll just share how I think about altered mental status. So there are two mnemonics that I use when I think of altered mental status. The first one is the famous IEO tips. And I think the IEO tips is good to use, especially when you are still trying to organize your thoughts, because it's broader. And the second one will be abridged. It will be an abridged version, and therefore it's shorter, but every letter contains many things, and therefore I think that one can be used later on. So I believe everyone is aware of AEO tips. So anything can go in there, alcohol. So the next letter is A. A for electrolytes, epilepsy, I, intoxication, and then there are infections. So infections, altered mental status, you talk of something like meningoencephalitis. Yes, cerebral malaria can cause altered mental status, and many other intracranial infections. And then for O, you are talking of overdose. So someone has an opioid overdose. Yes, that is for O. And then U, something like uremia. T, you can put in trauma there. Yes, so I believe everyone is aware of the IU tips. And then the next one, the other mnemonic that I use, the shorter one is MIST. So MIST, M stands for metabolic. So metabolic, now you have a lot of things in there. That's why I say it's abridged, because you find that the things that you find in AAO tips, you lump them together in a single letter. So for example, when I talk of metabolic, hepatic encephalopathy, uremic encephalopathy, they will all go in there. Hyperglycemia, hypoglycemia will go in there. So that is metabolic. And then I is for infections. So the same infections that I mentioned, meningoencephalitis, cerebral malaria, and others. So even disseminated toxin in the brain or neurocysticercosis can also present with altered mental status. And then S is for structure. So structure is something like a subarachnoid, for example, or an intracranial tumor, or anything structure. And then T for trauma. So all these are possibilities in this patient. So let's get more history and see where it takes us.
Okay. So since this patient was considered to be altered, the history was first obtained from his uncle, who lived with the patient for the past 1 month. And the uncle reports that one day prior, He came from a trip and told the patient to help with unloading some stuff from his car. And the uncle noticed that his nephew wasn't well. He seemed to be in short of breath and he was breathing rapidly. When the patient was asked what was wrong, he replied that he doesn't feel well and want to use the bathroom several times to feel good. But whenever he go to the bathroom and tries to use water, the water burns his hands. Uncle also reports that his nephew kept his hand on his genitalia all the time. And when he was asked why he's doing that, he said it helps him feel better. The uncle reports that the patient has never seen or the uncle has never seen or hear his nephew in such a state before. There was no history of suggestive hallucinations of any kind or delusions of any kind. There was no history of fighting people or undressing in the public. There was no history of fever, rash, head injury, headache, focal deficit, visual disturbance, vomiting, diarrhea, abdominal pain. Uncle also reports that as far as he and other family members who know the patient, they've the patient doesn't use alcohol, doesn't use cannabis, cigarette, or any other substances. The patient is not on any known prescribed meds, and there is no family history of mental illnesses in their family. The patient has never been diagnosed or treated for mental illnesses before. That's it.
Okay. Is okay. So that's the HPI. This is a patient who comes from a trip, and then the presentation starts
No, it's
at
not the
that
patient who
point.
come from a trip.
Oh, so it's the uncle
It's
who came from the trip and is told to
yes.
unload some stuff from the car,
Yeah,
but then he's unwell.
yeah.
So the patient was at home.
The patient was at home.
Okay, so what I hear, he's trying to use the water and then the water burns his hands. Those are reports from the patient, right?
Yeah.
Yeah, so this patient is altered for a duration of 1 day. I mean, as far as I believe, so that is according to the uncle's history that he's been altered for a day.
Yes.
And, he doesn't have any fever, so the associated symptoms, no fever. Can I see that slide?
Okay. Yeah.
So no fever, no rash, no head injury, no headache. There are no focal deficits, no visual disturbance, vomiting, diarrhea, or abdominal pain. Well, so what I see here is this patient is having some undifferentiated encephalopathy. At this point in time, I can't say exactly from what, but the symptoms that I'm hearing could be due to my limited knowledge, or uh, but I see there are some bizarre symptoms. So the patient, I see there is an undifferentiated encephalopathy here. The water burning his hands. I mean, it's we know most likely physically impossible for water to burn your hands. It could be just an abnormal sensation by the patient himself, and then keeping his hands in the genital parts, thinking that it helps him feel well. So some bizarre symptoms. I just there is encephalopathy here, and what is causing it yet to be established. So I haven't made much progress, but the absence of some focal deficits, uh, vomiting, diarrhea, abdominal pain, fever, lowers the possibility of some things, especially infections, but we cannot completely rule them out. More data.
Okay. So, as far as family social history is concerned, this is a married man. He has two kids with no known illnesses. Works as a farmer. And he lives up country. He came from rural to the city to visit his uncle 1 month ago. That's it. If you can comment or if you can proceed.
No, let's just proceed. I do not see anything new there.
Okay. Now we go quickly to the general exam. So as you enter to examine the patient, you find him telling nurses that he think he was bewitched by a woman he had sexual intercourse with some days ago. And when you open the door, patient cries loudly in pain and begs you not to allow anyone again opening the door because the air coming through the door causes much pain to him. Patient is sweating profusely with tense neck muscles and he is breathing rapidly with force. He is oriented to self, people around, and place. He is febrile, he's not pale, he's not jaundiced, there's no skin rash, there's no lower limb edema. He is holding his genitalia out with a hand, and when you ask him why, he replies that it makes him feel better. When you ask him what happened, he tells you yesterday he felt shortness of breath and he wanted to use the bathroom several times, but whenever he touched the water caused so much pain to his hand. That's the reason also he doesn't want anyone running fluid to his veins. Also, beside the patient, you see there is a basin, and because he speaks several times, and whenever someone opened the door, patient cried loud in pain and got aggressive. He want to beat people. He don't want anyone to open the door because he said the air coming through the door causes a lot of pain. So you do the vitals. Pulse rate a little bit elevated at 104, blood pressure is normal, sweat rate elevated at 30, temperature is normal, and patient is saturating well on room air. Limited systemic exam because of the condition of the patient. You start with a neuro exam. Patient is oriented to people in place. Oh, let me allow someone and continue. Okay. Yeah. So he's oriented to time, people, and place. There is no facial weakness. There is no eye asymmetry. Limbs are moving normally. The cardiovascular system, you do S1, S2, they are normal, and there is no murmur. Respiratory system, tachypneic at 30, no crepitations. Upper abdomen, it is non-distended, non-tender, no organomegaly. Musculoskeletal system, there is tense neck muscles. That's it.
Okay. Also, uh, in the general examination, so there, uh, I would consider the statement that the patient thinks he's bewitched. So that one is this patient is having some paranoid delusions. The patient has delusions, and then those other things, abnormal sensations. So water causing pain. That is so for this particular patient, I'm not sure if I'm using it loosely, but allodynia. So that is something that it's a stimulus that doesn't cause pain, but then it causes pain to the patient. I do not see to be very organic, but it could be organic. So the patient has some paranoid delusions, and then this other thing that when you open the door, the patient cries in pain, and then he's sweating. This patient is sweating profusely, and then he has tense neck muscles, and then he has tachypnea and some slight tachycardia. The pulse rate at 104. Tense neck muscles, diaphoretic, and then he's spitting every time. Okay. Uh, so I from this physical examination, let me see the systemic examination if I can pick anything. Okay, so it's just tense neck muscles.
Mhm.
Okay, so well, some things could be unrelated here, but let's see. The patient has paranoid delusions. The patient is diaphoretic. He's sweating profusely, and then he's tachypneic and tachycardic with tense neck muscles, and then some bizarre symptoms. So could this be something organic? Maybe. So, for example, but we do not. I should say this is a difficult spot. I'm not exactly sure what is happening, but I'm just trying to think about some possibilities. For example, the patient sweating, and then he's spitting every single time. So that means there is a lot of saliva. Acetylcholine could be involved, for example. So at this point in time, I should say I'm switching to system two thinking. I'm trying to think very slowly because I'm not sure what is happening. Uh, what you've mentioned so far, uh, I mean, apart from there are very loose associations, I cannot recognize any specific pattern in what is going on, and therefore I'm trying to think slowly and see if I can connect the dots. So the patient sweating profusely, and then the patient is spitting. Acetylcholine. So if acetylcholine, if you have muscarinic overdrive, so you have a lot of acetylcholine, uh, these patients will be the patients will be wet. So, for example, the saliva that the patient is producing could be because of a lot of acetylcholine. Now, what exactly can cause something like that is, for example, if there is a toxicity with organophosphates. Yeah, so those ones, organophosphates, acetylcholinesterase, yes, organophosphate poisoning, for example. But another thing that loosely comes to mind is something like so some of the symptoms, for example, something like rabies. For something like rabies, people will have these psychotic features, and then uh, they do not want noises, and then all the other bizarre symptoms. So organophosphate poisoning, rabies, although just like I say, these are very loose possibilities that I see. And then apart from that, the tense neck muscles, what do they tell me? So this patient is also having it's a sort of a sympathetic overdrive with the respiratory rate being high and the pulse rate, but the blood pressure isn't going in the same direction. The blood pressure is normal. So I do not have a lot of differentials here. I do not have a lot of differentials. Whether it's yes, it could be an acute process. Also, we cannot rule out a possibility of things like cerebral malaria, for example. But the fact that the patient is not having other symptoms, the absence of fever, some joint symptoms, makes infections like malaria less likely. So I would lead more in the direction of some intoxication, organophosphates being one of them. We cannot rule out substance substance use, for example, cannabis or any other illicit drugs causing these symptoms. So yeah, those are my thoughts at this point. Maybe I'll get more thoughts as we proceed.
Okay, so we go on. It's a short case. And here are the labs. They are unremarkable. White count 6.2, normal differential, HB 13.4, platelet 311, urine analysis normal, MRDT is negative, BS is no parasites, RBG 5.3, ESR 14, creatinine 92, BUN 3.3, AST is 24, ALT is 31, ALP is 52, bilirubin total is 11, direct is 4, and HIV is negative.
Mhm. Is there anything else? Or this is the end of labs?
I believe this is the end of labs.
Okay. So a full blood picture and remarkable. MRDT negative, no malaria parasite, seen RBG is normal. ESR is normal. Creatinine, BUN, liver enzymes, bilirubin, direct, total HIV, all negative. Okay, so unremarkable labs. Unremarkable labs. I mentioned malaria. So with a negative BS, negative MRDT, malaria is out the window. So uh, what are the other possibilities? Okay, I talked about a possibility of an intoxication. Intoxication from yes, a substance like cannabis or other illicit drug use. But apart from that, intoxication from things like, well, so the patient is now in the city. We do not have a history of any exposure to things like pesticides, for example. So an intoxication could be a possibility. And then apart from that, I talked about rabies, but we do not have a history of being bitten or anything. But again, this is not a typical presentation of rabies, so I just threw in randomly. So another thing is another possibility. Let's see. The patient has tense neck muscles, but we do not hear about other muscles. So I'm thinking of a far-fetched possibility of tetanus, but again, we haven't heard if the patient has any trauma lately, had any trauma lately. But yeah, so those things I am thinking an intoxication from the substances I've mentioned. But if we talk of other things, a distant possibility of rabies, and that is based on my limited knowledge of rabies. I know the other symptoms which I do not see here, and then the tense neck muscles also a loose association with tetanus. So intoxication and those organisms that I mentioned there, and then so uh, apart from those, because those ones are organic, so something inorganic, a brief psychotic disorder.
Mhm.
Yes, so those are my thoughts for now.
Those are very good thoughts. Okay, so there is not much to show here, David. What do you think this is?
Okay, so that's the end.
Yeah, it's a very short thing.
Okay, so we have a 28 years old male with an unremarkable past medical history, a patient who is not known to be on any substances, a farmer by occupation who lives in the rural area but came to the city 1 month ago. Then he presented with an acute presentation of altered mental status, which is characterized by altered mental status characterized by some psychotic features. So the patient is having some paranoid delusions, uh, is having some bizarre sensory symptoms which are I cannot connect to anything organic. And then on physical examination, the patient seems to be oriented. But yes, we didn't hear mental status examination. Maybe that would have helped us further. An MSc would be helpful in order to characterize this alteration in consciousness. But uh, on physical examination, apart from on physical examination, The patient is tachycardic, tachypneic, uh, and what else am I missing? Tachycardic, tachypneic. Yes, from the history. Yes, and the patient is diaphoretic. So I would lean more toward an intoxication. Now, what exactly is causing the intoxication? I'm not sure, but I've thrown in some possibilities. And then, apart from the intoxications, I mentioned those two organisms, but these ones are very far fetched. So, yes, that's my thinking.
Okay. So you think it's an intoxication?
Yes, intoxication, and then those two organisms I mentioned, and then apart from that, a brief psychotic disorder. But then, this there are these signs, especially the tachypnea.
Mm.
The tachypnea. Okay, let me think about some other possibilities. I mean, the labs are normal. The patient is not having any fevers. The patient is tachypnic, but with a normal respiratory exam, saturating well, so there is no hypoxemia.
Yeah.
And then he's also tachycardic, but the blood pressure is normal, and he is diaphoretic. So diaphoresis, tachypnea, tachycardia. Uh, Diaphoresis, tachypnea, tachycardia. Uh, Three possibilities here. I mean, but the patient is not on any medication. So apart, yes, I talked about intoxications. So other things that can present this way, uh, although the presentation of this patient seems to be very stable for the conditions that I'm about to mention, but they can also present the same way. Serotonin syndrome, uh, neuroleptic malignant syndrome. I mean, those few things, the tachypnea, the diaphoresis, the tachycardia, neuroleptic malignant syndrome, serotonin syndrome, they can all present that way. But then we do not have a history of if the patient was on any medications. So yeah, I'm thinking more of an intoxication. Now, infections. Is there an infection that I'm missing that can present this way? Maybe, but that hasn't crossed my mind yet. So those are my thoughts.
It has crossed your mind. Okay. So as I said initially, this is an inconclusive case, but the main reason for me to bring it here is to see how would you have done, and I believe it increases my confidence that me and the other doctor we were right in this case, because you also touched on something, although you're saying it hasn't crossed your mind. It did. I believe if you saw this patient, you would have had the diagnosis, because you would have opened up date maybe and read, do some reading of what you are thinking is going on with the patient. I think you would have had a diagnosis. So I missed the diagnosis I missed what happened to this patient, to be honest. And there is a registrar. I wanted him to be here today, but he couldn't. He's on call. So he consulted me. He came to my clinic. He was working in the emergency department. He said, Chief, come see one patient. And then I came, I saw the patient, and I talked to the uncle. And I said, this is acute psychosis. Send him to psychiatry. And then I left. But that doctor is very intelligent. He didn't say anything. And later he texted me. He said, what do you think about rabies? So I worked as a general practitioner in the village, and I've seen one case of rabies. It was a kid of 4 years old. And I remember vividly that kid was crying. He was scared of light, and was sweating profusely. He was salivating a lot. And that kid passed away. And then I said, no, I told this doctor, I've seen one case. It doesn't look like this. What I didn't think is I haven't seen an adult with rabies. So what I usually do, if some doctor comes with a different thought, I go home and I read. And then I went home and opened to read about rabies. And on that day, I decided to make some notes, which I can open and share it here so that you can see. So that you can see if we, yeah, I think this one. Can you all see this?
Yes.
Yeah. So I'll
Or
jump.
maybe everyone should just try and zoom in.
Do you see this?
Yes.
So I'll jump to the presentation, to the clinical presentation. So first of all, as as you see rabies and you're seeing symptoms like this, it means almost always death, except in rare cases. And rabies can start with a prodrome of a flu-like symptoms or paresthesia from the place where the bite happened. And there are two forms of rabies. The most common is called the cephalic rabies, which is 80% of patients. And then there is another called paralytic rabies, 20%. So as I was reading this, I realized I had missed an opportunity of patient with rabies. And you, David, mentioned this. And later on, you're saying it didn't cross your mind. It did. It did cross your mind. So uh, this patient with encephalitic rabies present with a low-grade fever, hydrophobia, and aerophobia. I bolded these two terms because in the literature written, if you see this, this is pathognomonic. It doesn't have to have an exposure or what. And what the patient was scared of water. He was scared to touch water. He was scared of we shouldn't learn lines in his veins. He didn't want water. And whenever anyone opened the door, air gushed in, he cried a lot. That was aerophobia. And then the profuse, the breeze, fast breathing that the patient had, if you saw, now I remember I was looking at the patient and I realized this is the guy who is forcing air out of his larynx, which translated to me this guy was having pharyngeal spasm plus the tense muscles of the neck that we were seeing. And then hyperactivity is another presentation. Some patient may present into coma, muscle spasticity, as we are seeing this patient. They can be in the neck, the back, or in the face. Hypersalivation, David, very nice. You picked that. I saw the patient was spitting and I saw the basin behind him. I didn't realize. But later on, I was reading, I realized that must have been hypersalivation. And you correctly picked this. They can also have lacrimation, sweating profuse as in this patient, dysphagia, agitation, combativeness. They can have confusion and they can hallucinate. So this is encephalitic rabies in 80% of patients. Paralytic rabies, 20% of patients, you can have a pseudo presentation like that of a GBS. And other things, if you can learn here, is that yes, the etiology is from rabies virus. The pathophys, the viruses enter through the bite, and it ascends from peripheral to the CNS, causes neuron dysfunction, and all mammals are susceptible to this disease. So, very important thing, epidemiology. We asked the uncle, has this patient been bitten by a dog or a bat, for example? He said no. And we also asked the patient said no. So that lowered the possibility of rabies to that general practitioner who was seeing the patient. But as I was reading, I discovered something new that I didn't know before. One is, first of all, the incubation period is 1 to 3 months, but it can range from days to many years. There is a case that was seen in the US. The patient came from Brazil, died of rabies, and there was no recent exposure. Later on, it was found out that he had an exposure 8 years ago. So it can be anything. And another thing, some patients might take small exposure, they might not take them serious. Like you have a wound and you have a leak from a dog, and you know that's not serious. You even forgot about it. And another very important thing is people who are exposed to bats, they usually forget and they will never notice. Someone you live in bats in your ceiling, and then at one point you get exposed to those bats who are harboring rabies virus. You will never notice. You later on present with rabies. And then we can have non-bite exposures, as I've talked about, and transplant organs with rabies. Labs are non-specific. They can be normal. You can be having leukocytosis and or CSF abnormalities. So, how do you diagnose rabies? This is the most important thing of this talk. It should be clinical, regardless of exposure. If you are seeing the symptoms as we've seen in these patients, they're having hydrophobia, tense muscles, they are sweating a lot, confused, they are doing all sort of things the patient was showing. You should consider rabies if even if there is no there is no history of exposure. But to confirm the diagnosis, you have to do a biopsy of the neck of the nape of the neck, or isolate the virus from saliva or anti-rabies antibody in CSF. Treatment, it can be either you choose a palliative way or aggressive way, depending on how the possibility of the patient surviving. For example, if a patient is young, they don't have comorbidities, and maybe they have a history of receiving vaccination previously, you should pursue an aggressive approach. Admit them as ICU, give them vaccine, give them a rabies immunoglobulin and antivirals or and ketamine. But otherwise, most patients will die, and they need a palliative care with a diazepam, morphine, haloperidol. Here are some of the differential diagnoses like HSV, West 9, CNS vasculitis, and others. If someone has an exposure, they should have a PEP with a vaccine and rabies immunoglobulin. Now, what happened in this patient is so when I told the registrar to refer the patient, the registrar did refer the patient. Later on, as I read and realized I made a very big mistake, we had to call now. We look at the number in the system. We couldn't get these people. And then we called to the hospital who has referred the patient. It seemed they didn't go to that hospital. We called in the ICU. We did hear such a story. So we missed an opportunity. Maybe we could have taken more and more history, or we could have seen the outcome of this patient. Yeah, so this was the case. David, you got this case right because I believe I didn't have the idea of rabies when I saw the patient. For you, you would have opened your up to date and see you if you ask the patient no exposure, you would have opened, let me see rabies, and then you would have realized this was rabies. So kudos to you, brother. You are the only person who can take basic science and translate it into clinical science. I can never do that. Yeah, that was it.
Thank you very much. So first of all, let me just say this was interesting. It was interesting. So at some point, I was completely stuck, and I think today I have understood better the term that the eyes can see what the mind doesn't know. Yeah, because there were some things there. For example, yeah, I think I have a fading memory of hearing that people with rabies are afraid of water, but then I could not put that into context in this patient. I didn't know about aerophobia at all, and then I think I just based on a few components of the presentation, I just threw in the differential of rabies randomly, based on my limited knowledge of rabies, because I haven't attended any patient with rabies. So apart from the distant memory of reading about it many years ago, I do not have something very solid about rabies. So okay, I think it's a challenge to me. It's a challenge. I'll definitely after this, so in a few days to come, maybe tomorrow, I'll go and read seriously about rabies and just increase my knowledge on that. So I think it was a good case, and it challenged me a lot. And so yes, it just tells me I have to do more reading. There's a lot to be done.
Okay, you almost make me believe photographic memories exist. So you read in the basic science and you see, you remember something like that. Man, that's superb.
Thank you, and I'm just happy that at least I mentioned it at some point, although it was not my provisional, but at least mentioning. So I'm happy that I beat you on that bet.
Okay, but in real life, I believe you would have had this right because you would have asked the patient if they have exposure to any drugs or poisons, and then no, and then you go to one of your mentioning differentials is rubbish. You would have gone to rather than if you saw that, you would have thought of this. But to me, if you also think of this, that guys thought of this, I'm thinking of this, and then this is up to date. There is, although I don't have a definitive that I should do a biopsy, but I believe we had a patient with rabies that I missed.
Well, and so what's interesting here among the differentials, you see, we have this picture of we have this picture. So I believe every one of us has a certain picture of a certain disease when they hear about a disease. For example, you hear about you hear about rabies, you think of someone who is barking like a dog, and then them being wet. So the patients being wet, I think, is one of the things that I distantly remember. But then the absence of a recent dog bite, because that's what we are used to. That probably, so for someone to present with rabies, maybe they would have a history of being bitten by a dog, by a stray dog, uh, in a few days past. But then you do not have a history of a dog bite, and therefore that lowered my possibility of thinking about it tremendously. Although uh, even my knowledge, I think my knowledge of rabies was very, very little, and therefore I couldn't pick. So, for example, the hydrophobia, I interpreted it as this is a non-painful stimulus, and then it is producing pain in the patient. So I thought of it as allodynia. And then with the paranoid delusions, I thought maybe this is not something organic, most likely psychosis and intoxication. So the possibility of rabies or even the tetanus that I mentioned was very distant. But I'm grateful to have at least thought about it. So the next, I think my next job is to go and read and do some solid reading about it. So I can be able to consider it next time if we have any suspicious case.
Sure. It was a short case.
Yeah, short and sweet.
Yeah.
Right. So any questions, any comments, any teaching from our colleagues who have been listening? Karibuni. Sioni mikono. Are people around? Alex.
We've been
Okay, tunaanza na nani Mudhiri afu tutakuja kwa Alex.
Yeah, okay. Thank you, Dr. Joseph and Dr. David, for the case. It was very interesting, but it scared me because I didn't know if bat bites may go unnoticed. I didn't know that, And I was once exposed to these bats. I was living in a house where there was a lot of of bats, but uh, they never bited me. But for this sentence of being that they can bite you, but you can't notice it, it's still scaring me. So thank you for the presentation. It is good. I think it has had many thoughts to me. Thank you for that.
Karibu sana. Alex, au Alex umeshashusha mkono? I see Kazaura has a hand up. Alex, if you are around.
Yeah, I am around. So the case was really interesting. I must admit, I never thought of. I thought of a viral infection, but I wasn't that specific like how the case went about to think about rabies. I didn't even think, but I was carried away with the psychotic symptoms, but the sweating and tachycardia uh, and that tachypnea carried me away towards intoxication, especially drug of abuse. And I was thinking maybe this patient fits from rural, maybe someone here in town just fooled him and all that. So I was trying to think about that and totally. So I really appreciate David's way of thinking. And
Sure.
Joseph, you're really doing a great job to bring this case. It's really interesting to remind us of these things. So you guys are always putting us on our toes because the cases keep on becoming interesting day by day, and even it makes us await the weekend anxious because we know we are going to get something that will feed our brain and keep us alive in medicine. If you are not getting interesting cases like this one, it remind you things that you might consider non-existence because you might forget them. Rabies is like it's not a common thing. Personally, I just managed to see one patient when I was doing undergraduate studies, when I was on junior rotation, fourth year.
Mm.
And I didn't like to go into that room because I was afraid. They said he might bite you. He was a guy, so I was afraid even going there. So it's nice. Thank you, Joseph, for this case, but also David for the approach. You went so wide. You tried to explore a lot of differentials, which makes us aware also how to approach cases like this one. Thanks, guys.
Yeah, before you finish,
Thank you,
Alex. So,
Alex.
Alex, you trained in Morogoro, right? Undergrad.
Yes, undergraduate, I was at
Yes.
Morogoro regional there.
Yes.
We stayed
Yeah.
there for 1 year for junior rotation.
Yeah. And
In fact, we were the one who initiated the process.
sure.
In
Now,
at St. Francis, there were two patients.
mm,
So we said we needed to go to Morogoro town. So it was lucky to
yeah,
hear the story of that patient.
that makes a lot of sense because I also I saw my case of rabies in rural Morogoro. This patient came from rural Morogoro.
Okay,
Yeah.
that's interesting.
Yeah. When I was there, I remember also there is this One Health thing. The people from animal sciences trying coming together with people with medical people trying to deal with zoonotic diseases and diseases from animals to human beings. There are programs there because of things like this. It's a lot there. So that's another thing.
Kazaura.
Hello, Joseph.
Mm,
Thank you for a nice presentation. And David, I think this is a good case and it has opened up my mind. Rabies, as David said, is something that most of the time we forget because of the reality of the disease. So from the initial presentation of this patient, my thoughts were probably this patient had temporal lobe encephalitis that most likely is due to herpes simplex infection. So why I thought of this is because most of the time patients who have herpes simplex encephalitis present with those features of encephalitis, but also they will have some personality changes. But again, I couldn't, or I was not sure if they can also present with those hypersalivation and the wetting and everything. So I think it's a good case, but for me, I thought of the possibility of a temporal lobe involvement as a sequel of herpes simplex infection. And I'm glad it was on the differential diagnosis as one of the possible disease. But all in all, I think this was a good case, and it has opened up my mind. And I think in the future we won't miss a diagnosis of LABI. Thank you, David, and Joseph, and all members that have commented on this case.
You're
Thank you.
welcome. You're welcome.
Asante sana Joseph. Okay. Anyone else?
Chief Irene aseme neno.
Irene uko kimya sana leo.
Tulitaka
David,
discuss.
Karibu.
asante. Jose, umesemaje?
Tulikutaka udiscuss leo.
Aha,
Tunajua ungepata hii
I-
right away.
we Jose, rabies mi nimeiona wapi? So I think I just echo what everyone has said, and I really didn't think of rabies kwa sababu actually ni muda mrefu mi I've never sat down kusoma kuhusu rabies kwa sababu ya hiyo rarity and ukiacha zile the general common knowledge and given that hakukuwa na history or risk predisposition ambayo ingetrigger a thought of rabies. So I think David did very well thinking about it and putting it into context. And I think huyu patient anaweza akareflect some patients ambao oftentimes unajua mgonjwa ambaye ana present na psychosis, delirium and psychotic features, sometimes ndio hivyo these patients end up being admitted in psych. So I just wanted to ask this patient, you said you were not able to trace the patient, so you are unsure whether the patient is alive or dead, right?
Yeah, I cannot tell.
Masalu?
Yes.
Yes. Okay. And then I wanted to ask about the hydrophobia. The hydrophobia in this case was in the sense of a feeling, an abnormal sensation, a feeling as though the water burns the patient. So nilikuwa najizani ile hydrophobia ni ile the hydrophobia ambayo tunalifaa hapa kwenye ni ile ambayo unakuta patient anaogopa kunywa maji kwa sababu ya spasms. Is it the same thing?
Yeah.
Hii perception, abnormal perception of stimuli aliyokuwa nao mgonjwa, ukiacha aerophobia, I can understand the aerophobia triggering yes. Hasa hii hydrophobia ambayo yeye ilikuwa ni altered perception of stimulus. Is it the same as the one that a patient anafia kunywa maji kwa sababu ya laryngospasms? Yes.
Yeah, sure. So issue ni inavyoanza. So truly as you're saying, initially wanaanza kupata laryngospasm and when they drink water wanaona kama shida, wanaanza kuogopa kunywa maji tu. Wakienda wanaanza kuogopa hata tu site ya maji. Another way ni hii ambayo anaweza kawa nayaona maji yanaumiza, and then later alone hataki hata site ya maji au kuguswa na maji aina yoyote.
Okay, sawa, asante. I think I also need to read more kuhusu rabies kwa ajili ya kucement, lakini thank you for sharing the case and thank you David for the discussion.
Asante sana.
Kwa hiyo huyu mgonjwa itakuwa alipigwa antipsychotics somewhere kule, si ndio? ile triple therapy.
Okay, kama angeenda kwa sababu hospitali ambayo tulimpa rufaa nilipiga simu ICU, maana hamna, nikapiga simu internal medicine pale hamna. Maybe kama
Sababu ya ICU ilikuwa
ah,
nani Joseph? Kama mlimrifaa kama psychosis, do you think people could put him in ICU wakati alikuwa ana vitals ambazo they were relatively more of a global dysfunction?
Yeah.
Like the vital sign derangement were more of a sympathetic.
So tulipiga simu kwa mtu anayefanya kazi kwenye department ya internal medicine na ICU ndio iko huko. Hakuna.
Okay.
And then ICU nako hakuna. Labda kama alipelekwa kwenye psych tena sasa.
Okay, sawa.
But you referred him as a case of rabies, right?
No. Tulifaa kama acute psychosis.
Acute psychosis, okay.
I believe walienda wakapata diagnosis ya kweli.
If inavyoonekana hapo, history was really key. The fact kwamba the thought after someone thought about it, ingekuwa rahisi kutrack back history, lakini kama ulivyosema, if you don't think about it, it is difficult to notice it unless for someone who has attended cases za rabies and has come across several of them, inakuwa ni rahisi kuona na kudetect mapema. Because oftentimes we would start to think of the common things. Yes, unless someone ambaye ameshawahi kuattend or something like this time the symptoms would really trigger. Otherwise you would lump the symptoms as part of psychosis, with the delusions and the altered perception to stimuli. You would really think of it as psychosis, and kwa sababu ni young 28, unadhani mostly the intoxications and stuff. Kwa mtu kuja kuifikiria rabies, I think it would come very later. Kwa mtu ambaye hajawahi kuona and the symptoms do not ring a bell. I really it would be, I think yule registrar alifanya a good job. Did you ask him how he thought about it?
I said kama Dave, inaonekana yule jamaa atakuwa Dave baadaye, kwa sababu he said aliwahi kusoma hivyo.
Okay, sawa. Asante. Maybe we hear wengine if they have ever attended cases rabies, if they have come across, maybe they could also share.
Clara, I see you have a hand. Karibu.
Maybe am I raising my hand?
Yeah, it
kept
coming and going.
I was actually laughing because I'm with somebody, and she was listening to our presentation and all that, and she was asking me, like, what do you get to do if at all the rabies is caused by a dog bite? Do you have to, for what she knows that we're supposed to look for the dog and kill it. Maybe as part of management and all that, I had to ask her, like, why should we kill the dog? Why should we look for the dog and kill it? Is it part of the management? Then I started laughing and I was pressing the button. But anyway, I had a relative. I never had an encounter of a patient with rabies, but then I had a relative who had rabies, and he actually died at Mloganzila. He was actually the first patient to be admitted at Mloganzila when it was opened at that time. So he had the symptoms that was similar to this, but at that time I think I was not very knowledgeable with a lot of things, so I was not sure what was going on. But then he had this aerophobia. He had complaints of he had confusion and everything. And apparently, by the time they had a diagnosis that it was rabies, it was too late, and he died at Mloganzila. So as Irene said, I think the main thing is that rabies I think it's rare. Most of us have not come into contact with such patients. So I think this is a wake-up call for most of us who are practicing and are seeing these cases, a lot of these cases. Maybe it's a wake-up call to always think of rabies, whether we have a patient with a animal bite or not, considering the fact that you mentioned about the, what is this, the bat, that usually you can go unnoticed. So I think, yeah, it's a nice case. Thank you so much, Jose and Devi, for the presentation. Once again, we learned. Yeah, that's it.
Thank you very much, Clara.
So uh, I do not see any other
Sorry to
notes.
interrupt.
Karibu Irene.
David, sorry. David,
Hey,
sorry.
karibu.
Yes, Joseph, you didn't comment. Yes, you can hear me.
Mm.
Hello.
Yeah.
Oh yes, I said, Joseph, you didn't comment on Mudhihili's call, concern or comment.
Mm.
What do you think about what he expressed?
Mm. Yeah. So I went reading also on how to protect ourselves from these things, and in for example, in selecting who should receive a vaccine for rabies, a PrEP vaccine for rabies, anyone coming into contact with bats should be receiving vaccine, and then we shouldn't live with bats inside our houses. That's what I understood. Because if they can come into contact with you and you don't realize it, that's that's not a risk to go on with.
Yeah, but we believe Mudhir is safe because I believe it's been a long time and 8 years. That's why it
Joseph,
was a case we put.
Joseph,
That's rare. So if there is anything, if anything, I think for most it's within a short time. So you can relax. You are safe.
Okay. So should I
Kazaura.
take the vaccine?
Jose,
Hello.
like,
Hello, Kazaura. You have a hand. Karibu.
No, I just want to give a little comment on Dr. Clara's question on why in the community the dogs, if they bite someone, they are killed.
thank
I
you so
think,
much. Thank you.
I think the issue here is that it is believed that if a dog is not sick, maybe hana kichaa, it should not bite unprovoked. So kwa hiyo kama mbwa akimng'ata mtu unprovoked, then kwenye community it is believed kwamba ana kichaa cha mbwa, so that is why he's killed, so that he cannot bite any other person in the community. I think it's the same as for snakes. I don't know, but I think they are killed because of that, so that they cannot bite anyone else in the community.
That
But
makes a
again, I just want to ask a question. So for maybe Joseph and David, if we encounter a patient with rabies, with classical features, classical symptoms of rabies, what is the line of treatment? How do we go about that case? So in a real world situation.
Yeah. So first of all, once you present with symptoms, survival is very rare. They say throughout history, there are only 30 cases that are documented that people survived with rabies. Then now, if you want to treat, there are two approaches. Either you choose a palliative or you choose an aggressive. An aggressive means you want to manage the disease.
Yes, unakat. Or is it just me? Can
I
can
can't
you
hear.
repeat what you said? Ulikuwa unakata kwangu. I didn't hear.
Yeah, I'm saying first of all, it's very difficult to survive rabies. Only 30 cases that have been published since 1950s throughout the world that people survive rabies. And in terms of management, there are two options. You can choose a palliative option or aggressive. Palliative is so how do you choose? someone who is more likely to there are people who are more likely to survive, and there are those who are more likely to die. So who is more likely to survive? Younger patients, um, uh, less advanced disease, and they've received vaccine previously. These have a high likelihood of surviving compared to someone who is old, more advanced disease, they have comorbidities, they have never received a vaccine. So a palliative is you help them die in peace because chances are they will die. Give them diazepam, give them morphine, haloperidol in a quiet room. Aggressive, if you want to treat them, you admit them in ICU, you give them vaccine, you give them rabies immunoglobulin, and you can give them antivirals like ribavirin, and also you can give them ketamine. But again, you can do this and then survival still it's not promised. I think I've tried.
So it's one of those viral illnesses where mortality is almost 100%.
Yeah, it's the most lethal infectious disease.
Okay, thank you.
Okay, asanteni sana for joining. So, of course, this is to me. I'm not sure about everyone else, but it's a lot of fun,
Yeah.
and I think we get something new to learn every day. So, as for me, for example, I think interpretation of some things I need to work on that. And then these conditions, I believe if I go and read about rabies now, I'll understand it better than if I just went on and opened Harrison's, for example, and read it without hearing a case. So I think it's a good learning opportunity. And again, every single day keeps humbling us that we identify our gaps, we realize that there is a lot that we do not know, and therefore there is a need to do more and more reading and practice what we are reading. So let's keep reading. Let's make those good physicians.
Sure.
And so to Joseph, thank you very much. I think the work that you are doing is unmatched. Uh, collecting these cases, seeing these patients, following them up until you have a diagnosis. I think since the beginning, everyone can testify that they are not easy cases, and therefore the fact that you made those diagnoses in the first place, you are the best man among us. So keep up the good work. We learn a lot. We learn a lot from you. So looking forward to more cases, and maybe next time I believe just like we had a talk, maybe next weekend I believe we'll have a new discussant. Someone will discuss a case they know themselves. Irene, unamkono.
Yes, I wanted to ask Joseph, in my records, I gather this is the sick case. Ni kesi ya sita. I have missed something.
Devi and I keep track. Devi.
I believe so hapo katikati I didn't note, but I believe this should be the, because we did two cases and then two, yeah, this should be the sixth one. 6 cases so far.
Okay, sir.
Yeah.
Asante.
This is recorded. I think you
Karibu.
can have it on YouTube.
Ndio
Thank you
ile
very
link,
much again.
ndio ile link ulotuma Joseph.
Yeah, nitatumia na hii.
Haya, sawa.
Yeah, so this one is I think Jose uanze sasa ile nani tabia ya YouTubers ya kwamba kindly subscribe and turn on notifications for more content. So madaktari, we have that channel Afro DX. So I think I shared the links to the case that we discussed last weekend. So share it widely with others, wa subscribe na turn on notifications so we can learn together.
Sure.
All right, good night everyone.
Good night.